Okay, we started. It's fine.
Hello, everyone, and thank you very much for joining our Sleep Science Friday. It is my pleasure to introduce our guest today, Professor Joerg Steier, who is the President of the British Sleep Society and the Professor of Respiratory and Sleep Medicine at Guy's and St. Thomas National Health Services Foundation Trust and the Chair of the Respiratory and Sleep Medicine Department at the King's College London in the United Kingdom. Professor Steier is an expert in respiratory physiology and sleep disorder breathing, and we hope that today he will share with us some of the insights in respiratory physiology, recent advances in the field, as well as the sleep-related news from the United Kingdom. Uh, Professor Steier, are you ready to proceed with our questions?
Absolutely. Thank you very much for having me. It's a pleasure to talk to you.
Thank you. So during sleep, our body goes through some physiological changes, including those related to breathing, such as the relaxation or decreased muscle activity in the upper airway muscles. In healthy individuals, it might be not a problem, but in some patients with certain anatomical or structural features, it might lead to the narrowing of the upper airway and result in snoring and sleep apnea. And moreover, there can be some individual variation in respiratory physiology. So when we approach a patient, should we consider this individual variation and how can it play into diagnosing and treating of sleep disorder breathing, such as obstructive sleep apnea?
Thank you very much for this question, Ludmila. And yes, we are living in a time where individualized care is ever more so important to get it right for the patient, because sleep apnea treatment might not just be a one-size-fits-all approach. We do know that patients who come typically can be well controlled with CPAP therapy, but then not everyone uses CPAP for the rest of their life. So there are other treatment options and they are more or less suitable in some patients, but it comes down to the individual phenotype. So the question that you just put out to me raises really the possibility to discuss phenotyping in a patient a little bit more so. The Harvard model suggests that there are different factors contributing to the pathophysiology of obstructive sleep apnea. It comes down to upper airway collapsibility, to the arousal threshold, whether the patient wakes up, to the upper airway gain, and to the loop gain. And all these features are summarized in a model abbreviated the PALM score, the PALM score, to define what kind of treatment in what patient is more likely to succeed. This might include the stabilization of the upper airway structure from an anatomical perspective with CPAP therapy, down to maybe some drug therapy to alter the apnea threshold. And we are at a time where we understand this more so now, and where we can, in the physiological sleep lab, investigate what works for the patient. So it comes down to individualized care.
Okay, thank you very much. I know that you have recently published an article on this obstructive sleep apnea phenotyping. And as I understand now, it's not now only the hypothetical hypothesis. It doesn't have only hypothetical value. You already implement it in your clinical practice. Is it true?
Yes, indeed. There are certain features that some of these phenotypes mark in the polysomnographical recording in the overnight sleep study, and that are more or less suitable to try the one or the other treatment approach. You're right, there's an open access publication and the listeners can read this in detail, but yes, if you are trained to look at certain features, then you find what I just mentioned, the arousal threshold, the upper airway collapsibility, and the periods assigned to the sleep stage at night, you find markers for this in the polysomnographical recording. And therefore, even to the clinician not necessarily having access to the measurement of a critical occlusion pressure of the airway in standard clinical care, these kind of features can translate into everyday clinical practice and help the physician guide and understand which treatment best to select for the patient.
Okay, and then coming to the question of the choice of the treatment, what are the current available treatment options for obstructive sleep apnea?
Yes.
Except CPAP.
Thank you. Yes, indeed. We already mentioned the CPAP therapy, continuous positive airway pressure, and this is the gold standard all across the world. Here in the UK, we have the NICE committee, the National Institute for Clinical Excellence, guiding us with guidelines, and they say for moderate severe sleep apnea, CPAP therapy remains the gold standard. But then for mild sleep apnea, a mandibular advancement device, something that looks like a gum shield, might actually be also very helpful to advance the jaw, to treat the patient and keep the airway open at nighttime. So in the milder versions of obstructive sleep apnea, a mandibular advancement device might just be suitable as well. Then it's always important to rule out upper airway pathological anatomy. So ENT review, although in the minority of the patients actually surgery is indicated, but if there is typical deviation from normal anatomy, then an ENT review is always warranted and can reveal something like enlarged tonsils, adenoids, polyps, something where maybe there is a target zone for surgical treatment as well. More on the rarer side of treatment options is maybe the maxillomandibular advancement therapy with the max-fax surgeons teams. And then there are, of course, more experimental treatments that are currently maybe not established in clinical practice, but running through clinical trials, such as myofunctional treatment approaches. You will be aware maybe of the didgeridoo story, yeah? But also, of course, electrical stimulation. And particularly over the last decade, this story around electrical stimulation became a little bit more obvious in that the hypoglossal nerve stimulator treatment was established in the US, approved by the FDA following the STAR trial published in 2014. And our own group has been working in recent years more and more on a non-invasive approach. We call this transcutaneous electrical stimulation in sleep apnea, TESLA. And we are currently also in a trial where we run for the first time TESLA at home. So there are different treatments available for the patient, in addition, of course, to lifestyle adjustments, weight control, weight loss, possibly postural advice. And I'm pleased to say that the European Respiratory Society are currently working on recommendations for non-CPAP therapy. The last guidelines were published in 2011, but the next ones are due to publish in the near future. So there is more to come.
Yeah, that's very interesting and developing field. And I think we will talk later about these electrical stimulation methods, which are very interesting and bring a lot of interest and attention. But now I would like to ask you about potential ways to predict who of your patients would respond better to some of the treatments, and whether there is any approach for such a prediction and how it can imply in your clinical decision.
Okay, so this is in the context of the electrical stimulation that you're interested in.
No, I think that about electrical stimulation, maybe we can talk in more detail later, but in general, do you have any clinical approach to predict, like to differentiate patients? For this, you give CPAP, or for this, you give mandibular device. or something else, or
Yeah.
not any approach?
Yes, that's a very good question, and typically it's difficult to work out the sophisticated approach towards the individualized care. In our clinical service, which is a very busy service, we are sitting in the center of London, and we have presumably around 20,000 patients on CPAP therapy. It is difficult to stick to individualized care. So often what happens first is that we run standard diagnostics, offer standard treatment, and see who succeeds with, for example, CPAP therapy. We have then, since 2015, actually set up a CPAP adherence clinic, patients who struggle with this treatment, because if you look into long-term outcomes, then actually after 3 months, you have maybe a quarter of patients who start to struggle with CPAP therapy. And after a year, it might be a high number, about 50% of patients might not use CPAP therapy after 1 year as they should. So we have actually CPAP adherence clinics where we then bring the patient back and sit down with them and look more into the details. I explained the phenotyping approach, which is usually updated by an up-to-date sleep study to get us a guidance as to how we can in the individual case, find the right kind of solutions. We are, of course, then led by the current existing recommendations, as, for example, from NICE here in the UK, or from the European Respiratory Society with the non-CPAP recommendations on evidence-based care. But then patients sometimes come back not once, but several times, because they might have tried CPAP therapy, they might have tried mandibular advancement devices, they might already have been to the ENT surgeons, and all that didn't help. In that case, we have established a difficult to treat obstructive sleep apnea MDT, a multidisciplinary team meeting, where we bring actually the different faculties around the table to decide which treatment is best, which has not been tried, and where we also, in an academic health sciences center, offer the patient to be enrolled in clinical trials to gain access to treatments that are maybe more experimental, maybe not on the market just yet. And so this is eventually coming down to, yes, individualized care, but then you need to pick the right patient to find the treatment that suits. It's not easy, and this is the approach that we've tried. And it's certainly not the end of the line yet, because this is under discussion, under permanent review. And as we get the dental team, the ENT surgeons, the neurologists involved to help us with the treatment, we have also many more trials coming up over the years that actually potentially will be available to the patient who has failed first line, maybe second line, maybe third line therapy.
Okay. I see that you have a very structured and but difficult system of approaching to these patients. And one more question is about, do you use telemedicine services to increase the adherence of these patients, and does it help or not in your country?
So we do monitor adherence, yes, and we have now, particularly during the pandemic, more stepped into remote monitoring pathways. We typically limit this to 3 months, so that we don't carry on beyond the 3 months. At 3 months, it must be established that the patient uses the treatment as they should, and if not, then we bring them back. Yes, there are luckily some advantages that are now available, maybe easier than even before the pandemic. And so patients are quite grateful that we reach out to them and now have many more appointments where actually they don't need to travel to central London, but they can sit just at home and participate. And we have the data that we would like to discuss with them. Yes, this is certainly a new feature of the year 2020.
Yeah, that's true. And you have already mentioned that low adherence is one of the biggest problems with these patients. Like more than half of our patients, they do not adhere at long term to CPAP therapy. But what are other big difficulties in treating patients with obstructive sleep apnea from your experience and your opinion?
So this is, of course, dependent on the phenotype. In the end, it comes down to also lifestyle. We are living in a time where non-communicable disease is responsible for many conditions that we see, and where this is often coming down to sedentary lifestyle, to unhealthy diet, and in the context of the obesity pandemic that we face as well across the world, this impacts then on problems with nocturnal breathing, of course. So without actually also getting dietitians involved, without getting maybe in some occasions other teams like the bariatric surgery involved, one doesn't really have the entire cascade of treatment available. However, taking it back to the patient, yes, we can do everything we want to try to help, but if the patient does not really take on the message and makes a change to their lifestyle often, then it is somewhat difficult to get a compliant patient. Just like we know with diabetes or hypertension, treatment adherence is important. And just like with diabetes and hypertension, if overweight and obesity contributes, then improving the weight is certainly very promising. Potentially, you can reverse obstructive sleep apnea if obesity is a contributing factor. And so it comes down to having a good relationship with the patient, convincing them to actually not follow any wrong health beliefs or leaving the onus just with the doctor. It's about building up a trustworthy treatment relationship with the patient so that they can rely on what we recommend, but also do their own bit in order to improve their health and their long-term outcomes. In the end, here in the NHS system, we have had an analysis looking into CPAP cost efficiency, and the fact is, in order to be cost effective, even CPAP needs to be used in the long term, more than a year ideally. And so one doesn't win if you offer the patient the perfect treatment, but they stop using it a couple of weeks after they've come to see you. You need to get them engaged, keep them engaged, convince them that this is what's right for their health, and not only there and then, but that they ideally need to change their lifestyle, which is difficult. I appreciate this. Here in the UK, we have a big problem with obesity, and this is obviously something that will keep us busy for years to come.
Yeah, and unfortunately, sometimes all our attempts to convince our patients to adhere to CPAP therapy fail. And then we have novel options, and the ones you have already mentioned, the electrical stimulation techniques. And I think you're the expert in this field, because you and your co-authors, your co-workers, you are working on developing this technique and investigating it. And so please, could you tell us a little bit more about this method, about your findings and your experience with this method?
Yes, of course. Thank you for asking. So electrical stimulation is not a new story. Electrical stimulation to reach out to skeletal muscles and achieve a contraction of the muscle, this is relatively old-fashioned physiology, and a lot of medical students have done this with a frog in the lab or so whilst going through their university time. However, to do this in the context of treating obstructive sleep apnea is still relatively new because it's complex. It's not that straightforward. once we fall asleep, the dilator muscles of the upper airway start to relax because the efferent output from the central neural system have a diminished activity, and therefore this relaxation leads to a collapsibility of the upper airway. The airway narrows and then possibly collapses, causing snoring, upper airway resistance, and sleep apnea. What we are trying to achieve by using electrical current is reaching towards the upper airway dilator muscles, keeping them active whilst the patient is asleep, and via that effect, keeping the airway open so that the patient does not obstruct, continues to breathe, and the sleep apnea should be offset. So why is that so difficult? Well, it's an difficult to access area with very sensitive parts on the skin, on the chin, and it's deep buried down in our body between the oral cavity and the voice box. So to reach actually the genioglossus muscle, ideally the largest and strongest upper airway dilator muscle, is not that straightforward. The invasive methods reach typically for branches of the hypoglossal nerve, which is in charge of the genioglossus innervation. And the transcutaneous method has been tried from different directions, and we have, like others, tried this from the submental route, so in the submental area. The invasive approach works well with an implanted pacemaker, but it's invasive, therefore costly. But the method has been sophisticated, and in recent years, with more centers delivering this, the training being provided has minimized the kind of side effects that were observed. I think the STAR trial observed something like 2% of SAEs in their follow-up period. So that's the invasive approach. However, we thought, what if we could actually deliver current to these muscles, treat sleep apnea, even if it's not as good as CPAP therapy, but if we did this non-invasively, many more patients might actually benefit from this. Why? Because it's relatively low in terms of side effects. It's not risky. It's like a TENS machine. TENS machines are used even in pregnant women to alleviate labor-related pain. So even with a baby in situ, one would not shy away from using a TENS machine. And so we thought, what happens when we apply a TENS machine on the upper airway? We started to do initial work on this and published this in 2011 in Chest. And that was at that time promising in that we stimulated patients with sleep apnea, short periods at nighttime, and saw that we offset many obstructive airway events, but it wasn't as effective as CPAP therapy. We could reduce the severity of the sleep apnea by roughly 2/3 if you looked at the apnea-hypopnea index or the oxygen desaturation index. So there was something in this. And then we were running also a randomized controlled trial with a SHEM control, where the computer selected whether for the whole night patients were stimulated or received SHEM treatment, meaning no electrical current. And we published this in 2016 in Thorax, and we showed again, yes, this is effective. This is possible to deliver all night long in a sophisticated manner, the electrical current with the right frequency, but with certain gaps to avoid muscle fatigue. Because when you contract a muscle after a while, perfusion slows down and metabolites build up and the muscle fatigues. So there's a force fatigue function that you need to consider. And the more force you select, the shorter actually the effect will last. So we needed to develop a stimulation program overnight that could last for hours and hours without fatiguing of the muscle and allowing perfusion of the muscle. So that gives you the idea it's not that easy. And if you then factor in that when you use particularly the transcutaneous approach, the non-invasive approach, you are not meant to wake the patient. then this becomes highly complex. There were publications in the 1980s in the Blue Journal where people basically zipped these muscles with a high short current, and yes, reported this helps sleep apnea. But then a year later, another group came and showed actually you did achieve nothing else, but you woke the patient up, and by waking, the upper airways obstruction ceased. The patient didn't have sleep apnea any longer. So what we needed to develop was a stimulation pattern that kept the patient asleep, that was tolerable, that was not necessarily disruptive in that it wouldn't wake the patient, and that could last all night long to allow to avoid fatigue of the muscle. Now, whilst we were doing all this, luckily the field developed further, and a lot of knowledge came from the hypoglossal nerve stimulation trials, because they also used drug-induced sleep endoscopy to identify at which level the obstruction sits and whether or not it responds to electrical stimulation. And so we understand by now much more so who benefits. And this is typically the slimmer patient where you have not so much of a load on the upper airway from the neck circumference. And in our study that we published in 2016, we saw that all women who participated, who have typically slimmer necklines, were responders to this treatment, because every treatment, when you test it, has responders and has non-responders. And it's about identifying who would benefit so that you can offer them the right treatment. So we are still working on this, and we've taken it now to the technology that we can offer the patients in the so-called Tesla Home trial 3 months of this treatment at home. Now, we would have finished the trial without the pandemic this year, but we are still on it. And actually, the patients are very, very grateful to still run with the assigned treatment arm. We will bring them all back and have just longer follow-up periods, hopefully very soon when the pandemic is over.
We will be looking forward for the results of this Tesla trial. And in one of your recent publications, you applied ultrasound to measure the effects of this stimulation, if I understood correctly. Yeah. So can you use this ultrasound to also to predict the response, or it's only to measure the effectiveness?
Yes, it's a very good point you make. We thought that if we could employ ultrasound of the upper airway to look at the genioglossus muscle, we could maybe work our way towards predicting response. The fact is, ultrasound of the upper airway isn't very well described. So it was about establishing some standard planes to have a good look at the muscle fibers. And I think we've got there now. What we need to do now next is to correlate the outcomes of the Tesla Home trial with these kind of measurements to see whether actually our prediction is correct, and whether the patients who respond well whilst you're visually analyzing them on the bedside are also those that eventually at 3 months have a very good responder rate to the treatment. So the last word there is not out yet. We are still waiting for the data to come in, but it would be fantastic, because if you had a bedside tool like ultrasound, which is widely available to predict response, that would be much easier than anything else invasively. The hypoglossal nerve stimulator studies, as I pointed out, they're using often drug-induced sleep endoscopy, which is fantastic, but also costly and an endoscopy procedure where patients need to be sedated, and therefore not necessarily something that can be delivered just there and then in clinic when you see a large amount of patients.
And so for maybe not now as the study is ongoing yet, but for future, what would be your approach to this electrical stimulation techniques, both invasive and transcutaneous? Would you consider them only as a second-line therapy, only for those who do not tolerate CPAP, or for some patients, maybe you would consider them as first-line therapy?
Thank you. Now, we have to be guided by the evidence, of course, and the evidence at the moment with the current guidelines for non-CPAP therapy, published in 2011, says that there is not sufficient treatment to offer this kind of experimental new pathway. So with that in mind, I don't think that this is first-line treatment. Having said that, there is obviously a lot of new evidence over the last couple of years that now is incorporated in the current revised guideline due to be published soon by the European Respiratory Society. Again, this brings us back to maybe some meta-analyses that have already been published, not the least one of our group earlier in the year, where we looked at all electrical stimulations for sleep apnea trial, and not only randomized controlled trials, but also non-randomized controlled trials. So in the meta-analysis, we found that, yes, you can actually successfully stimulate using both invasive and non-invasive methods, and you can succeed with the treatment, but it does not seem to be as good as CPAP therapy. Thus, in our trials that we are running, we have learned that over time, we needed to consider certain in- and exclusion criteria. I mentioned earlier that particularly the slimmer population might benefit. By slim, I mean there is a cutoff with the body mass index of around 32. From 35 onwards, it really becomes a larger load because the neck is very bulky. But also in terms of severity, one needs to consider what happens. I mentioned earlier that electrical stimulation is maybe not quite as good as CPAP therapy in offsetting every respiratory event. The hypoglossal nerve stimulator is maybe treating even more obstructive airway events than the non-invasive approach, where one is further away from the muscle. But what we've seen with the transcutaneous approach is that we can treat roughly 2/3 of the obstructive events. So if you downstage someone from an apnea-hypopnea index from just above 30 by 2/3, then you change the category. You bring them from severe sleep apnea maybe down to mild sleep apnea, or maybe no sleep apnea at all, if you're lucky using this method. But if you had someone with very, very severe sleep apnea, take someone with an apnea-hypopnea index above 100, and you downstage them by 2/3, then you would still talk about severe sleep apnea. And therefore, one would rather step away and say, this is not first line, not second line therapy. It's again, often these patients who are maybe morbidly obese and where the physical body load is a significant factor for this method, and where one would step away and say, this might not be the right thing here to do. Yeah, so I think at the moment, this is certainly not first-line therapy. CPAP therapy and mandibular advancement devices are amongst this. There will be more evidence out soon. And I'm not saying this is the last word, but I would rather think that this is second, third line therapy of experimental methods. Yeah.
Yeah, thank you. And I understand that it's not enough evidence yet, but what do you think? Can we in future maybe use this method in combination, like combine with CPAP or some mandibular device, some other options?
That's a very clever thought. And we've thought about this in our research group many times, because yes, if you think of collapsibility of the upper airway and someone who doesn't use CPAP because the pressure is very high, what happens if you just apply a little patch here, stimulate the genioglossus muscle, change the compliance of the upper airway, keep it a bit stiffer? It might still collapse, but not so easily. You might actually down titrate the pressure on the CPAP device because the critical occlusion pressure might change, and it will be harder for the upper airway to collapse. So which could make it much easier for the patient to tolerate CPAP. So a combination of treatments does make sense. And I've seen there are already a couple of publications out there where something like what I just described, the combination of CPAP therapy is actually done with a mandibular advancement device. I could see in future maybe studies where this could be also tested using, for example, electrical stimulation, for example, non-invasively. And it's a whole new research project. And in many ways, also drug-induced sleep endoscopy could be validated maybe with a non-invasive stimulation, so that actually one could test there and then whether patients are responders, even prior to implanting maybe hypoglossal nerve stimulator devices. So this is in the direction of making it more informed and evidence-based, but we're not there quite yet. The ultrasound is another step in this direction, and I'm sure we will hear so much more in years to come, as the interest in this topic has only just started.
Yeah. And again, about electrical stimulation, as I understood, in your Tesla trial, you had some certain inclusion and exclusion criteria, but you didn't apply the phenotyping approach for selection of the patients. Do you think in future the phenotyping approach can be applicable for electrical stimulation, transcutaneous or invasive stimulation as a method to select patients for this procedure?
I think so. Every bit of information that we have available before we would apply a novel method makes it more or less likely that we're successful with this, and also helps us to predict whether patients actually will like the response, which is highly likely if we address their symptoms, not only the numbers, not only the apneas, but their symptoms, which is typically something like sleepiness. Yeah. So it's going to be important to consider this, of course, in all of these studies. And I agree that phenotyping can be combined with novel experimental methods. What we should never forget is that there is no success if we just offset the sleep apnea, but the patient has still the ongoing problems with sleepiness. So one needs to understand at the heart of the symptom what the patient complaint is. And if you address this, then I'm sure we keep many more patients with us in future years.
Yeah, that's true. That's the basis of personalized medicine, I think. And then coming to another field of sleep medicine, not only sleep breathing disorders. I know that you and the British Sleep Society are dealing with other sleep disorders. And today, on the 4th of December, the British Sleep Society is holding a narcolepsy webinar update. Could you please comment a bit more on this event, and also on what is the situation with narcolepsy in general in the United Kingdom?
Thank you very much. Yes, and thank you for giving us the chance to do this interview on one of our event days. So this is the last event of the year. We have run many webinars in the pandemic year, presumably like everyone else. But this is really a very nice program. We will start off with the chair of the Narcolepsy UK patient charity. So he will give us the patient's perspective and also help us to raise awareness of this condition, which is maybe still not in the mainstream of many primary care physicians. So then we will have experts from the nursing team over doctors to researchers speaking about the condition and how we best treat this condition. We have Professor Emmanuel Mignot dialing in from Stanford, and it's going to be really a fantastic opportunity to join us. So if you find the time, please link in. It's a free event for delegates. In the end, it comes down to creating an expert network, because we want to have the patient and public involvement, and we want to have the sleep center with the expert taking care of the treatment for these patients. Now here in the UK, it comes down often what kind of treatment you have available depends often, unfortunately, still on the region where you are. If you're in a region like central London, where you have access to many sleep centers, then you might be very fortunate. Whilst unfortunately, if you're far away from areas where they have large sleep centers, where you might get access to certain drug therapy for narcolepsy, then this is more or less still a postcode lottery. And so what we are working on is in collaboration with here in the UK, it's structured via clinical commissioning groups, CCGs. We want to, in the primary care scenario, reach out and allow patients wherever they live to have access to certain treatments, which are often highly specialized, but also costly, and therefore maybe not at the forefront of every GP's prescription list. So we have in our sleep center the fortunate circumstance that we have over the years got a sleep pharmacist involved who helps us not only with reviewing patients who come to see us and issue prescriptions locally, but who also links with GPs and clinical commissioning groups all across the country to help us establish pathways to get the patients the treatment they need once they are established on the treatment, and continue the prescription of the drugs they need in the local environment. So it's going to be about this. It's going to be about networking, and it's hopefully also a very nice educational event. Unfortunately, we're still missing in these virtual contexts the drink thereafter, to have a chat with everyone around. But I do hope that via these events and others, we will also more so maybe on a European base link in with other networks that gather data, that combine in the EU narcolepsy network, for example, databases which can be good for the clinical care of the patient, but also further research projects in future and academic collaboration, which would be delightful.
That's true. And also the British Sleep Society has announced that it is launching the BSS strategy. Could you tell us a little bit more what it is, what we should expect of it?
Yes, of course. Thank you. And the BSS strategy is something that we've been working on over the last year. I took over presidency almost exactly a year ago, and we started a task force to work on this because we wanted to give the society more structure. So the slogan is fairly simple: healthy sleep for all. But what does it mean? So we had a mission and we had a vision. And we wanted to support excellence across all aspects of professions in the multidisciplinary care of sleep. And we wanted to be at the heart of a vibrant sleep health community. So this was supported by defining values and priorities. And the values, just to summarize here maybe, were around innovation and improvement, evidence-based practice, patient and public and professional engagement, and transparency and inclusivity. Now, these values we want to apply throughout what we do. And we do this particularly by focusing on education, clinical practice, and research. So the tripartite agenda. The overarching theme, though, and that's why I'm so delighted that we get the chance in this interview to talk about this, is communication. So one of the priorities that we identified is communication, and that means communication between professionals via the network, but also towards the patient or the general population or policy makers. So with that, we are going to start the BSS strategy today. It's going to be on the BSS webpage, and whoever wants to read it, there will be an open access version of it, but the outline I've presented here now.
Okay, thank you very much. We are looking forward for reading this BSS strategy and to see how it is being implemented in UK practice, and probably other countries can also take something for their own practice. And of course, nowadays, when we are still in the second wave, in the middle of the coronavirus pandemic, and for some countries it's already third wave, we cannot bypass and avoid this topic. The coronavirus pandemic has brought great burden for the healthcare systems worldwide. And I know that you have published a paper on crisis management during coronavirus era, pandemic era, and also the BSS has also delivered several key documents on the management during pandemic with regard to the sleep disorders. What could be some key points which you would like to emphasize from these papers for our audience, for general population, for general practitioners, and for sleep professionals?
Yes, thank you. And you're absolutely right. We are still in the middle of the second wave and waiting for a solution to get out of this. So just like us, there were, of course, many publications out there this year. Ours are all open access and on our webpage for anyone who wants to read them in more detail. But it came down to many factors. Three of them I want to stress a little bit more in detail here. First of all, because a large number of patients who are under sleep center care are those on CPAP therapy. Now, CPAP therapy was classified as an aerosol generating procedure, an AGP in the UK, I assume in other countries as well. And therefore, there was a lot of worry about whether to continue with CPAP, whether to stop, what to do if you come to hospital, etc. So our advice in the BSS statement on the pandemic and sleep-related issues towards the pandemic was to continue if you're symptom-free and not to worry about the use of CPAP therapy. However, we know by now that even relatively asymptomatic, maybe even sometimes completely asymptomatic patients might have coronavirus in their airway. Now, to what extent this can infect then others in the household, that might be the reason for worries and anxieties. And if you are living on your own, it's not a problem. Again, you should continue with CPAP therapy, because if you have coronavirus, it's likely that CPAP does the right thing for you. It treats you, it normalizes your breathing, it optimizes your airway patency at night, and it keeps the oxygen level up, it inflates the chest. It does really work very well. Only if you are worried about your household and infecting others whilst you have coronavirus, then we said that actually in line with the OSA Alliance in the UK, our advice was you can stop shortly using your CPAP therapy. We do know from CPAP withdrawal trials that withdrawing CPAP for a week or two does not necessarily cause you many detrimental long-term problems. It might make you more sleepy. Yes, it might make you more sleepy. So if you drive a car or do other wise work that is at risk, if you're sleepy, then you shouldn't do that. You should seek always, of course, advice from the center that provides you with the CPAP therapy. But if you're worried that during an acute COVID infection, you might infect someone in your household and there's no chance for them to isolate from you or you to isolate from them, then we said you can stop CPAP therapy for 1 or 2 weeks. And then once you're healthy, you should resume with the treatment. So that was one point. The other point was that mental health, general sleep-related issues seem to be at the forefront of the nation's concern. That was enlarged due to worries, anxiety in times of existential fears due to the pandemic, but also due to the lockdown, due to the lack of everyday routine, due to the lack of exchange, maybe loneliness. And therefore, we identified that mental health hotlines here in the UK were under incredible demand and delivered a lot of work. So access to therapy for mental health was another big issue which we have addressed in this statement. Insomnia, of course, being one of the predominant features of populations affected by the lockdown that was noted. We had an UK-wide study where we saw that basically 68% of patients, of people going through lockdown had disrupted sleep that they complained about. Some people who were very stressed out before the pandemic had the paradox adverse effect. They said it was their best sleep ever, but that wasn't the majority. The majority was actually many people had problems, and they persist. And the longer lockdowns persist and the pandemic is ongoing, the more this will also affect, as a knock-on effect, the mental health. So this is something that needs to be addressed. And that brings me to the third point, which is, of course, the issue in any healthcare system, the funding, because having access to mental health support, access to care is directly dependent on how public health is funded. And we have published earlier in the year on, we called it the load capacity model on healthcare during the pandemic, but in the end, it's an economical cost benefit analysis. And it basically shows that the healthcare system that invests into good healthcare in non-pandemic times will also be better off when then the emergency strikes. That is just an observation. And I think the takeaway message from that is really that one needs to be aware there's no shortcut to happiness. Well-invested healthcare systems that are better prepared to cope with increase in demand and any other adjustment are typically better positioned when it comes down to times of need. And this year we have seen this extraordinary scenario with the pandemic, creating still ongoing need long beyond this year to support our population, not the least with sleep, but in our field, of course, we can be of help with sleep. And so remote access to insomnia support, etc. This is something that in future, maybe with virtual cognitive behavioral therapy classes also, we can support, and that we can maybe accelerate to have available to provide on a wide front best possible care for the population.
Thank you very much for these messages, which I think are important for both sleep professionals, healthcare workers, and general audience. Thank you very much. Professor Steier, I would like to thank you so much for your talk, for the interview today, for sharing with us your experience in different fields of sleep medicine, for sharing your results of your studies and your colleagues. And I would like to wish you a great narcolepsy event today. And I think that our audience, those who are listening to us, can still join to this event. And also, we are looking forward for BSS strategy to be published and to reading it. Thank you so much.
Thank you very much for your time. And I hope this is enjoyable to anyone who watches it.
Thank you. Have a good day.
Bye-bye.